Diagnosing infections of the reproductive tract. Sexually transmitted infections, STIs, are caused by organisms present in the reproductive tract or from the outside during sexual contact. Modes of transmission, person to person, during childbirth, transfusion of blood products, tissue transfer. STIs and their causative agents are listed below. In this lecture, we are going to focus mostly on the bacterial causes of STIs. In advanced microbiology, we will get into the viral and the parasite cause. Sexually transmitted diseases, STDs, are a diverse group of infectious diseases with a wide variety of pathogens and wide-ranging clinical manifestations. The preferred terminology is STI. CDC recommendations are annual chlamydia and gonorrhea screening for sexually active women younger than age 25, older women with risk factors such as new or multiple sex partners living in communities with a high burden of disease, and testing for chlamydia, gonorrhea, syphilis, HIV, hepatitis B for pregnant women. For men having sex with men, annual screening for syphilis, gonorrhea, chlamydia. For everyone between 13 and 64, HIV screening at least once. The top reportable diseases are listed in this table below. You can see chlamydia is number 1, followed by gonorrhea, then syphilis, and going down. Urethritis is inflammation of the urethra. Causes could be mechanical injury, chemical irritation, or infectious disease. Infectious urethritis is more commonly associated with organisms that cause STIs, but can be caused by others. Gonococcal urethritis is caused by Neisseria gonorrhoeae. This is gonorrhea. Non-gonococcal urethritis, NGU, is caused by Chlamydia trachomatis, which is chlamydia. You can pause the video and take a look at this table differentiating the different types. Gonorrhea is the second most commonly reported infectious disease in the United States. It's estimated that only 50% of new infections are reported. Highest incidence are in sexually active adolescents and young adults from 15 to 24 years of age. Approximately 80% of women and 10% of men with gonorrhea are asymptomatic, and this is how it's spread easily amongst populations. If you don't have symptoms, you don't know to get tested and treated. Chlamydia is the most commonly reported infectious disease in the United States. There's a bunch of different serovars or types. Some can be isolated from the eye and cause trachoma, and those are endemic in developing countries, mainly Africa. Other ones are associated with the genital tract. Gonococcal urethritis, dysuria, and urethral discharge without urinary frequency or urgency. So gonorrhea specifically binds to columnar epithelial cells of the genitourinary tract, including the urethra, cervix, endocervix, Bartholin glands, anal canal, pharynx, and conjunctiva. Incubation is 2 to 7 days. 90% or more of males experience a purulent urethral discharge, whereas women often have no symptoms for weeks or months. Diagnosis is only made after examination. NGU incubation is 7 to 21 days. Symptoms arise less abruptly. Symptoms in women: dysuria, pyuria, less often, urethral discharge. When accompanied by cervicitis, a woman may experience abnormal cervical-vaginal discharge, intermenstrual bleeding, pain during vaginal sex. Patients are much more likely to be asymptomatic than those with gonococcal urethritis. In most cases of urethritis in men that are left untreated, spontaneous resolution occurs. There can be complications which can lead to acute prostatitis, epididymitis, and urethral stricture. Epididymitis has the potential to cause sterility. Ascending infection occurs in 10 to 20% of undiagnosed women. It can trigger pelvic inflammatory disease, presenting as salpingitis, endometritis, internal abscess, and chronic pelvic pain. Perinatal exposure to either N. gonorrhea and C. trachomatis can result in severe disease in newborns, such as sepsis, pneumonia, inclusion conjunctivitis leading to blindness, ophthalmia neonatorium, which can result in perforation of the globe of the eye and blindness. Laboratory diagnosis is based on the presence of mucopurulent or purulent urethral discharge. demonstration of 2 or more leukocytes per high power field in a smear of urethral exudate, and positive eucholate esterase test on first void or urine. In addition to those basic tests, we have molecular tests that exist. Those molecular tests are capable of detecting gonorrhea and chlamydia routinely. Gram stain of male urethral exudate with gram-negative diplococci is considered diagnostic for N-gonorrhoeae. We can't say the same of women because women have other organisms that are part of their natural flora that resemble those gram-negative diplococci. Specimen collection: pass a small swab a few centimeters into the urethra or by milking the exudate onto a slide for staining. A negative gram stain smear should not rule out gonococcal infection in asymptomatic patients, and follow-up testing is recommended. Here we can see the arrows pointing to the gram-negative diplococci. FDA-approved assays are listed here. And moving on to cervicitis. So inflammation of the columnar and subepithelial cells of the endocervix. Causes of infectious cases: most are chlamydia and gonorrhea. Others include trichomoniasis, which is a protozoan infection, genital herpes, or infections with mycoplasma and ureaplasma. Injury to the cervix, birth control device, douche, tampon, chemical irritation may also cause it. More than 50% of all women develop this condition at some point in their adult lives. Most common STIs in adolescent females. Risk factors include sexual activity at an early age, engaging in high-risk sexual behaviors, having a previous history of STIs, and having multiple sex partners. Cervicitis is considered the silent partner of male urethritis because symptoms are not always obvious, and women do not feel the need to seek health care from a licensed provider. Complications of unrecognized infections include pelvic inflammatory disease, infertility, ectopic pregnancy due to the scarring that can happen in the tube, chronic pelvic pain, spontaneous abortion, and cervical cancer. Symptoms may be mild initially and progress over time. Most common is vaginal discharge that may be gray or yellow with a possible odor. Other symptoms: abnormal bleeding, itching, irritation, pain during intercourse, bleeding or spotting after intercourse, dysuria, and sometimes lower back or abdominal pain. Symptoms in severe cases: profuse, almost like pus-like discharge accompanied by vaginal itchiness or abdominal pain. Laboratory diagnosis is usually performed clinically. Direct examination, as I mentioned, shows more than 10 white blood cells per high power field. Patients with symptoms of cervicitis are usually assessed for signs of pelvic inflammatory disease and tested for chlamydia and gonorrhea. Patients may also be tested for bacterial vaginosis and trichomoniasis. Cultures lack sensitivity compared with nucleic acid-based assays, so most common assays performed are amplified tests with high rates of sensitivity and specificity. FDA-approved assays are available in automated and non-automated formats, and rapid antigen tests are used as point-of-care settings. Additional tests may be necessary to confirm rapid test findings. Vaginitis and vaginosis are terms that are often used interchangeably, but they're completely different things. Vaginitis is an all-encompassing associated inflammation of the vagina, while vaginosis is a bacterial infection that's typically caused by Gardnerella vaginalis, and there's a few other species that can cause it. Vaginitis is more general, while vaginosis is specific. Causes: so vaginitis occurs when the mucosal lining of the vagina becomes inflamed and irritated, can be caused by bacteria, yeast, viruses, chemical or mechanical irritants. Typical signs: vaginal discharge, vulvar itching and irritation, often an odor. Associated disease is bacterial vaginosis, trichomoniasis, candidiasis. Distinction amongst these diseases can initially be made by observations of the vaginal discharge. So when we get a vaginal specimen, usually it's a swab, we can perform a wet mount on that swab, and we can look for whether we see bacterial vaginosis. Bacterial vaginosis, we would see epithelial cells, which are large cells that would have a whole bunch of bacteria on them to the point where the margins of the cell look cloudy or hazy. Those are called clue cells, and that would give us an indication that it's bacterial vaginosis. Trichomoniasis, if we had a swab, we would actually see the organisms that are pretty large. They would have flagella, and if the specimen was fresh enough, they would be swimming. And typically they swim around in circles and they move. Those are protozoan parasites that cause trichomoniasis, and they're very large and obvious and motile. Candidiasis, we would see budding yeast. So we'd see those large, perfectly oval-shaped yeast, and buds would be coming off of them. We don't typically do wet mount evaluation of specimens anymore. Now we do molecular testing for these. So molecular testing would look for the genetic material and be able to tell us if it's present or not. Most common, so bacterial vaginosis is the most common vaginal infection in women of childbearing age. Risk factors: sexual activity at an early age, having numerous, anonymous, or frequent changes of sex partners, having female sex partners, ethnicity, and frequent douching. Bacterial vaginosis occurs when the delicate balance of normal vaginal microbiota is disrupted and replaced by an overgrowth of specific organisms. In healthy women, the normal microbiota is mainly Lactobacillus species, and that helps maintain the pH of the vagina between 3.8 and 4.5. If that's disrupted, the pH increases. Semen has alkaline properties to it. So semen and frequent insemination is also going to increase the pH of the vagina, and that can throw off the vaginal environment enough to allow for the overgrowth of that, those types of species. If we do have vaginal pH increase, that allows for the overgrowth of species that are listed here, like Gardnerella vaginalis, which is most often associated with bacterial vaginosis, Mycoplasma ureaplasma, and then anaerobes, Prevotella, Porphyromonas, Peptostreptococcus, Mobiluncus. Distinct unpleasant odor, that of rotting fish without a true inflammatory reaction, particularly after intercourse. Why after intercourse? Because this bacteria happens to hang out in the fornix of the vagina. So surrounding the cervix, it goes up a little bit into the body cavity, and that creates a little pocket or a little cavity. Now the vagina is typically going to be that tube from the cervix to the outside of the body, but if we go into the vagina up to the cervix, on the outside edges surrounding the cervix, it goes up even further, and those pockets up there, that's called the fornix. During intercourse, the penis stretches out the vagina, and that opens up that fornix, releasing all of the bacteria and exudate from that area, allowing that to drain out, and that's why the odor is noted most often after intercourse. Patients with BV demonstrate a discharge that is usually milky, homogeneous, the thin liquid adhering to the walls of the vagina. Discharge is often more apparent and odorous after intercourse, as I mentioned. Clinical criteria: we need to see clue cells on the microscope, thin, white, homogeneous vaginal discharge, the vagina pH of greater than 4.5, the fishy odor when 10% potassium hydroxide solution is added to the vaginal secretions. So we call that the whiff test, not commonly performed anymore, but I have seen it done in laboratories back when I used to work in clinical microbiology. But we don't typically perform this test. Now we do molecular testing. Gram stain is considered the gold standard. Examining vaginal saline wet prep for gram stain or gram stain for the presence of clue cells. And this is what I was talking about with the clue cells. So you can see the epithelial cell, and then the border is hazy because of all the bacteria that's clustered around the border of the cells. Other laboratory diagnostic methods: pH test paper to test the vaginal pH, culture, DNA hybridization test, rapid antigen tests. Trichomoniasis, I'm not going to get too much into this like I mentioned, but this is a parasite protozoan. It's the most common STI in the world. Approximately 70% of infected people in the United States show no signs or symptoms. Infections occur mostly in women. Commonly associated with other STIs, BV, or gonorrhea. Easily curable and not a reportable disease. Clinical manifestation is listed. Here we can see the strawberry cervix that's caused by trichomoniasis. And here you can see the organisms. Right here, you can see the flagella coming off of the organisms. So visualization of the motile trichomonads pouch inoculation, so we can inoculate it in pouch media. It'll grow in a pouch, and then we just put the pouch directly under the microscope, and we look for the presence of the organism swimming around. Oligonucleotide probe test and point of care rapid antigen detection tests exist. And here's some other assays that are FDA approved. Candidiasis is an infection with Candida albicans. Candida albicans is a yeast that's pathogenic, meaning that it can cause infection even in healthy individuals. Although oral thrush and other types of Candida infections are more associated with immunocompromised, Candida albicans vaginal yeast infections can happen in healthy individuals. Almost 75% of all adult women have at least one genital yeast infection in their lifetime. Candida is always present in the body in small amounts. When the imbalance occurs, like changes in vaginal acidity, the Candida can overgrow. It's not considered as a true STI because it causes similar symptoms in the female GI tract as other organisms described here, but it's just going to be listed here. Men are rarely infected. Yeast infections are most common genital infections affecting women. Hormonal causes of yeast infections, so pregnancy, ovulation, menopause, oral contraceptives, estrogen replacement therapy, that can all mess with the normal flora, which can mess with the pH of the vagina. There's immunosuppressive conditions that can lend itself, and it has highest prevalence in women of childbearing age who produce ample amounts of estrogen, which causes the vaginal lining to mature and contain glycogen, the preferred substance for Candida albicans. Itching, burning, swelling, redness with abnormal vaginal discharge. Usually it does not have an odor. In men, itchy rash or burning at the tip of the penis. Laboratory diagnosis, we would look at it under the microscope or perform the molecular test for this. Genital ulcer disease, so the disruption of the skin and or mucosal layer of the genital region. Most genital ulcers are diagnosed in the United States are attributed to herpes, syphilis, or chancroid. Herpes is a virus, so we'll talk more about that in advanced microbiology. Syphilis and chancroid are caused by bacteria, so we're going to talk a little bit more about those here. Less common causes, LGV and donovenosis. Multiple infections are possible. So genital herpes, there's HSV1 and HSV2. HSV1 is primarily oral, while HSV2 is primarily genital. HSV1 is mainly associated with the lips, gums, tongue, and other areas inside the mouth, cold sores, and fever blisters. HSV2 affects the genital area by sexual contact. This is the most common request for treatment of symptomatic genital ulcers in the United States, more common in women than men. From 70 to 90% of infected individuals are unaware of their infections. Asymptomatic or vague, or only vague symptoms. Syphilis, genital ulcer disease caused by the spirochete Treponema pallidum. It's an obligate parasite of humans. No other animal is a host or environmental reservoir. Epidemiology, about 12 million are affected each year. Primary, secondary, latent, and tertiary syphilis are the different stages of the disease. In primary syphilis, you see a canker that appears on the external genitalia. The canker is usually a little bit painful, but it goes away pretty quickly, and some people don't even see the canker. Secondary syphilis, you start to get a skin rash, mucocutaneous lesions, lymphadenopathy, and other types of symptoms. Organ involvement is possible, so sometimes we see hepatitis or inflammation of the liver, osteitis or the bones, and keratitis or the skin. CNS involvement may also occur. Condylomata lata mucoid watery-like growth, or wart-like growths, can be seen. Typically, secondary syphilis is not something we ignore. That's something we go to the doctor and get seen for. But if you don't, it can slip into latent syphilis, and that's divided into early and late latent syphilis. It's characterized by CSF abnormalities and the absence of symptoms. Indicators are elevated protein, decreased glucose, lymphocytic pleocytosis, or the presence of white blood cells. Untreated patients will relapse during their first year of the latent period. Then we get into tertiary. Tertiary syphilis is an immune sequel of primary and secondary syphilis. There's neurological symptoms, brain disturbances, cardiovascular effects, or late benign symptoms in which gummas, or nonspecific granulomatous lesions, develop. In tertiary syphilis, it usually does lead to neurological impairment that can lead to death. Congenital syphilis is when you're born with it, and that's deformities, rash, jaundice, meningitis, deformed bones, deafness, blindness, and others. So it's very important to test the mom for syphilis to make sure that this isn't passed to the baby. Dark field microscopy to see the spirochetes. Non-treponemal antibody tests like the RPR, RST, USR, TRUST, VDRL, or the treponemal-specific antibody tests, which include EIAs, fluorescent treponemal antibody absorbed treponemal pallidum particle agglutination. Diagnosis of congenital syphilis is complicated by the ability of maternal non-treponemal and treponemal IgG antibodies to cross the placenta. To differentiate maternal antibody from infant antibody, IgM-specific tests may be useful. Current testing recommendations: infants born to the mother who have recent serological tests results be evaluated with RPR or VDRL. Epidemiology, so caused by fastidious gram-negative bacteria, Haemophilus ducreyi. So cancreous, gram-negative bacteria, Haemophilus ducreyi. Major cause of genital ulcerative disease in Africa, Southeast Asia, the Caribbean, and Latin America. Incidence increasing U.S. Potential cofactor in the transmission of HIV. Clinical manifestations: painful genital ulceration, inflammatory inguinal adenopathy, and bubo formation. Ragged or uneven soft edge, and gray to yellow purulent exudate. The pathogen enters through microabrasions in the skin after intercourse. The papule develops 4 to 7 days after exposure. It develops into a pustule that ruptures 2 to 3 days later and forms a painful shallow ulcer in the external genitalia. Painful tender inguinal lymphadenitis occurs in nearly 50% of patients. Laboratory diagnosis: specimen ulcer lesion material and or bubo aspirate. Culture media: GC agar-based, hemoglobin, iso-Vitalex, and fetal calf serum. Mueller-Hinton agar with chocolate horseblood, and iso-Vitalex. H. ducreyi are pleomorphic gram-negative coccobacilli that occasionally occur in characteristic chains or school of fish. There are molecular tests available, but culture remains the gold standard.